Okay, can I get started? Can you guys hear me?
Yes, sir.
Sir,
Start,
please.
Okay.
sir.
Sir, please,
Okay.
no. Sir, please, just a minute, sir.
Okay.
Honorable President of Bangladesh Association of Urological Surgeons, Professor Habibur Rahman, learned speakers, honorable panel of experts, my teachers, my dear residents, executive committee members, and participants from home and abroad, like member of SARC and AUA. Very good afternoon from Dhaka. We all know we are passing a very bad and difficult time here in Bangladesh and also throughout the world as due to pandemic COVID-19. You know, many of our members are getting infected by corona, and many of us already recovered from the disease, but some other are already admitted in the ICUs, and we hope and pray for their early recovery. And during this unforeseen time, many of our collaborative society like American Urology Association, Society of International Urology, Endo-Urology Society, Urology Society of India, Urology Society of Asian Urology Society, and also the SARC Urology Society, they send their greetings and wishes during this pandemic time to all the members of Bangladesh Association of Urological Surgeons. And during this time, difficult time, like all other society of the world, all the scientific activity is limited within the webinar now. We already did 2 or 3 webinars from our society, and also the 2 webinars from the SARC Urology Association and other Urology Society of India, and also from the Urology Association of Asia and Philippine Urology Association. We attended that webinar and we learned a lot and during this unprecedented time. And our scientific committee is doing very hard and they work together, our scientific secretary and scientific chair and co-chair, to make a year calendar during this difficult time of COVID-19. And learned viewer and presenter, you know, the bladder cancer is a very common cancer in the man, and it is almost the 4th most common cancer in the man. And globally and also in our country, it is a very much common urological cancer. And fortunately, more than 50% of the cases presented in non-muscle invasive cancer. And if you diagnose it early and treat it early, it is almost curable. So today we'll hear and learn and review from our learned speaker. Those who have not need any introduction, you know, Professor M.S. Chaudhuri is the mentor of our mentor. He is the teacher of our teachers. Professor Rajiv TP, he is also one of the eminent and emerging urologists from India, and currently he is the Secretary General of USI. And another is Professor Motahar Ahmed. You know all of them. And let us, with no more talk, let us start our talk today. Our learned audience, please take the opportunity to review the bladder cancer from basic to beyond. And dear resident, please learn from this talk today. Now I request Professor Ghulam Maula Chaudhuri, who is the head of the Uro-Oncology Division of Bangabandhu Sheikh Mujib Medical University, one of our senior member of the society, and our teacher, Professor Ghulam Maula Chaudhuri, please moderate the scientific session. Please unmute you. Yeah. Yes.
Thank you very much, Professor Chaudhuri, sir. I am Dr. Ghulam Maula Chaudhuri, uro-oncologist, Professor of Uro-Oncology, Department of Urology, BSMMU, and I feel pleasure and honored to announce such a renowned urologist, especially uro-oncologist Professor M.S. Chaudhuri. He is a son of the soil. It is our proud. And he is a professor and chairman of the Department of Urology at New York Medical College in Valhalla, New York since 2001. He was graduated from Osmani Medical College Sylhet, Bangladesh in 1972. Thank you very much, sir. I am also the fellow of the same medical institution, and he completed his residency in urology at New York Medical College in 1980 and fellowship training in uro-oncology at Roswell Park Memorial Institute in Buffalo, New York, 1981. He joined New York Medical College as a faculty of the same year and has been there since. He also served as a director of urology at Westchester Medical Center. His interest in urological cancer. He served as president of the New York section AUA and is a current member of the board of AUA. And he is honored as professor of urology in BSMMU. And he is such a dynamic and dedicated person who always try to share his knowledge with our fellow. That's why he established a AUA induction course in Bangladesh, and his enthusiasm to transfer update information and technology in Bangladesh. He started to introduce BOWS in AUA meeting and arranged for a BOWS slot for presentation. And it will never end to tell about him. He is an iconic person and is a mentor of us. Now I request Professor M.S. Chaudhary to start his presentation. Topics is low and high rate NMIBC, that is non-muscle invasive bladder cancer, updates and recent guidelines. Thank you very much, Mohammed Chaudhary.
Very good. Thank you, Dr. Ghulam Mullah Chowdhury. Thank you for that very kind introduction. Can you all hear me well? Okay, I'll guess you are hearing me well, so I'll start with the presentation. So I was assigned to talk about non-muscle invasive bladder cancer today. And what I'll try to do, basically go over a fairly simplified way of looking at non-muscle invasive bladder cancer. And I'll also give some of the highlights of the AUA guideline regarding the management of bladder cancer. So let me just see if I could. So I think it'll be very important that we look at how we stage bladder cancer. And if you could pay attention to this area, so that this is the lining of the bladder wall. So it starts, the innermost lining is the transitional cell mucosa of the bladder. And right beyond that is the submucosa of the bladder, and then is the detrusor muscle of the bladder. So the most common type of bladder tumor will be TA tumor. That's a papillary tumor which starts in the bladder mucosa and protrudes into the lumen of the bladder. That's the most common type. 70% of all non-muscle invasive bladder cancer are TA bladder tumor. Then you have carcinoma in situ of the bladder, which is right here. These are malignant changes in the transitional cell mucosa of the bladder. That's about 10%. And the next one is the tumor starts in the mucosa, but as you can see, it also burrows into the submucosa of the bladder, and that will be a T1 tumor. So collectively, carcinoma in situ of the bladder, the TA, and the T1, those three things will be called as non-muscle invasive bladder cancer. Once the tumor penetrates the detrusor muscle of the bladder, that's an invasive bladder cancer. And Dr. Rajiv Tipi, as well as Dr. Mutar Ahmed, will be talking about the muscle invasive bladder cancer. So just to go over again, so especially for the residents, that's the mucosa of the bladder, transitional mucosa, the submucosa of the bladder, and the detrusor muscle of the bladder. The tumor, the non-muscle invasive bladder cancer, starts in the mucosa. If it goes into the lumen of the bladder, that's the TA, that's 70% of the tumor. So we'll go to the next one, I think. So one of the things is, how do you, when you suspect somebody may have bladder cancer, and you suspect because of the presentation of patient, and most patients will present with gross hematuria. They might present with microscopic hematuria, and occasional patients will present with irritative symptoms such as urinary frequency, urgency, so on and so forth. So one of the guideline statement in AUA guideline is that anytime you suspect non-muscle invasive bladder cancer, you should really do an upper tract study. Because the patient are presenting with gross hematuria, you want to make sure there is no pathology in the kidney itself, that the kidney itself is normal. You want to make sure that the upper tracts are normal, there is no tumor in the upper tract, which might be responsible for the hematuria. As you know, for many, many years, we did an intravenous pyelogram. Very few people will use intravenous pyelogram right now, and primarily because that you cannot see the kidneys very well. A lot of time you do not see the collecting system very well. So the study of choice right now will be a CT urogram. So CT urogram is the study of choice across the world in most places, because you can see the kidneys very well and you can see the collecting system very, very well. So anytime you suspect bladder cancer, we should all do an upper tract study. And for me, the study of choice will be a CT urogram. Aside from that, we do a urine analysis just to make sure that the patient have microscopic hematuria. We do a culture to rule out urinary tract infection. And of course, you can do other urinary biomarkers such as a urine cytology. So urine cytology, as you know, has a very high specificity, that if the cytology is positive, almost invariably the patient has high-grade bladder cancer. On the other hand, a negative urine cytology does not rule out bladder tumor, because about 50% of low-grade bladder tumor will have a negative cytology. So a negative urine cytology does not rule out bladder tumor. A positive urine cytology tells you that there is something in the bladder mucosa or in the upper tract mucosa. The next thing will be a thoracystoscopy. And what they mean by a thoracystoscopy, that when we do the cystoscopies, both in male as well as in female, we should look at the entire urethra to make sure there is no urethral lesion. Especially in male, you may find prosthetic urethral lesion. So we do not go with a cystoscope blindly through the urethra. We should go under direct vision, so we can look at the entire urethra, both in male and females, look at the prosthetic urethra, look at the bladder neck very well. If you're using a flexible cystoscope, we should retroflex the scope to look at the entire bladder. Once you go inside the bladder, you really should look for that, how many tumors are there, what is the location of the tumor, what is the size of the tumor, does the tumor look papillary? Does the tumor look sessile? All of these abnormalities should be noted carefully in the medical record of the patient. And I think that should become a part of the patient's record every time the patients return. So when you do the cystoscopy, we'll know exactly what was found when we made the original diagnosis. So one of the clinical principles in the guideline, AUA guideline, is a thorough cystoscopy in every patient who are suspected of bladder cancer. One of the most important things for non-muscle invasive or invasive bladder cancer is the role of PUR bladder tumor. So when we make a diagnosis of a bladder tumor, like in this patient, there is a large tumor in the bladder. The goal always has to be a complete resection of the bladder tumor. And the way we go, that you resect the entire tumor, send that specimen separately to the pathologist. When you go down to the base of the tumor, that base should be resected separately. And that part of the specimen should be sent separately for pathological examination. So the pathologist can make sure, is there invasion of the submucosa or of the detrusor muscle of the bladder? So a complete TURBT always is the goal. Now, a lot of time we may not be able to do a complete TURBT in one session, that it is nothing wrong with it, that if we cannot resect the entire tumor because it is a large tumor, that is multifocal tumor, we can always go back and resect any residual tumor at a later date. So in this case, there is all of this tissue are basically has collected at the base of the bladder. We can send all of that thing. There is no way for pathologists to go through all of this thing and see which one is the top of the tumor, which one is the base. So we can be kind to the pathologist, send the top separately, and send the base, resected base, as a separate specimen. And that's what we are talking about, that if you cannot completely resect, go back and you can resect all visible tumors. Because intravesical therapy does not work very well when you leave residual tumor. And we are not going to expect, we cannot expect that the intravesical therapy is going to take care of residual tumor. So a complete resection of bladder tumor is the goal. One of the most important thing the guideline did, both AUA as well as the AU guideline, that every time we see a patient with bladder tumor, whether it is the first presentation or it is a presentation with recurrence of the bladder tumor, that we should really specify each time that what is the risk stratification of the tumor. Is it a low risk bladder tumor? Is it an intermediate risk, or is it a high risk bladder tumor? So from the first presentation or the presentation at recurrence, every time we should stratify what is the risk of the bladder tumor. So as you can see in here, this is a very papillary tumor. You know by looking at it that this looks like a low-grade tumor, very likely a TA tumor, a low-grade TA tumor. So what is the low-risk tumor? When the tumor size is less than 3 centimeters and it looks like a low-grade papillary tumor, and hopefully you resect the entire tumor and the pathologist will confirm that this is a low-grade papillary tumor. It is less than 3 centimeters. That will be considered a low-risk tumor. Then we go, what is an intermediate risk tumor? So intermediate risk tumor will be if the patient has, instead of one solitary tumor, there are multiple tumors in the bladder. The tumor is low grade looking, but it is more than 3 centimeters in diameter. Or you did a resection of a tumor, which was low risk, comes back in 6 months with 2 more tumors, then it's no longer a low risk, it becomes an intermediate risk tumor. And high-risk tumors is obviously, these are fairly solid-looking tumor. They may have carcinoma in situ or with or without it. So any high-grade tumor, T1 disease, with or without CIS, will be considered a high-risk disease. And what is the main difference between low, intermediate, and high risk? The higher it is in the risk stratification, the higher is the risk of recurrence, higher is the risk of progression into muscle-invasive disease. And that's why we want to risk stratify, because the treatment should be guided by the risk stratification of the bladder tumor. So if the students and the residents were listening, if you take anything from this talk, always make sure if you are having a bladder tumor, always risk stratify. Is it a low risk tumor, intermediate risk, or is it a high risk tumor? And this again tells you what is a low risk tumor. Less than 3 centimeters, papillary, low grade looking tumor will be a low risk. Intermediate risk will be a larger tumor over 3 centimeters, again, low grade tumor. Multifocal low grade tumor, recurrent tumor within 1 year. High risk will be any high grade T1 disease, any carcinoma in situ, with or without papillary tumor. Or if it's a high grade TA tumor, they will all be considered high risk disease. Now, this has been validated by many, but this is one of the more recent studies from University of Miami, where they looked at 398 patients. And in their patient, 92% of these patients were treated with intravesical BCG. About 46% of the patient got at least one course of maintenance cycle. And in their group, when they're risk groups, they had a 11.5% of the patient were low risk. Intermediate risk was 32% of the patient, and half of the patient, more than half the patient of the 398 patients were high risk disease. So because this is a referral center, that's why it doesn't reflect exactly what you might see in the community in the number of low, intermediate, or high risk disease. But the important thing what they showed, that the 5-year recurrence-free survival in the low risk, 43% of the patient had never had any recurrence. In an intermediate risk, only 33% had never had any recurrence. In the high risk, it was down to 23. So higher the risk, the more higher is in the risk stratification, higher is the chance that the patient will have recurrence of the tumor. Same is true for progression-free, that means going into the muscle wall of the bladder. So if it is a low risk, the chance it will progress is only 7%. That means 93% of the chance a low-risk patient will not become muscle invasive. Intermediate risk, it is down to 74%. That means almost 26% of the patient can eventually become muscle invasive. On the other hand, a high-risk patient, almost half the patient will become muscle invasive at some point. And that is the main reason we really need to risk stratify bladder tumor. Higher is the risk of recurrence, higher is the risk of disease progression. And this is exactly, again, it shows the same thing, that in the low risk is on the top, intermediate risk, high risk, higher is in the risk, more likely they will recur and progress. So how do we treat low-risk, non-muscle invasive bladder cancer? And again, the definition of low risk will be it's a low-grade TA, less than 3 centimeter, single solitary tumor. So our first job really is to resect this tumor. See this, you look at this tumor, you know it looks like a pretty low-grade tumor. So we resect the tumor, send the specimen to the pathology. There is a small tumor on the side. Most of the time, I will not go and resect this tumor. I might just fulgurate the tumor. So if it looks like a small, low-grade tumor, you just fulgurate the tumor. Again, if it really looks like a low-grade tumor, I don't think I'll become too aggressive in resecting the base. See, if it looks like a low-grade tumor, you do a good resection, and I think that should be good enough really on this one. So what is the most important thing you can do if you suspect that this is a low-risk tumor? The most important thing we can do immediately after the resection of that bladder tumor is installation of intravesical chemotherapy. Most of the time we used to use mitomycin C in there. Currently, I use almost exclusively gemcitabine, and I'll tell you the reason we use the gemcitabine. It is a single dose installation immediately after the transurethral resection of bladder tumor. And one of the main reasons we do that, because it reduces the risk of recurrence. Remember, there is very little risk of progression with those tumors. We are only trying to reduce the risk of recurrence of the tumor. If you're going to use the immediate installation, we do it immediately after the transurethral resection of bladder tumor while the patient was still under anesthesia. We will do that in the OR right at that time, but you have up to 24 hours to do it. You can do it in the recovery room, or if the patient goes home, he can come back to the office. But the important thing is it needs to be done within 24 hours of the resection of the bladder tumor. I think the earlier it is done, the better off you are. There are at least 3 large meta-analyses which showed that if you use the single installation of intravesical chemotherapy, it will reduce the risk of recurrence by 10 to 15%. It is most effective when the tumor is single, it is small, and it is low grade. That's when it is most effective. And it should be done within 24 hours. One of the side effects, especially when we use mitomycin for a long time, and I think it is quite effective in there, we found a small number of patients. I had 5 patients who had severe lower urinary tract symptoms. And usually it lasted between 3 and 6 months, but they all resolved, chemical cystitis related to mitomycin. So we try to use more gemcitabine now than mitomycin. What is the contraindication? When we do not put it in, if you suspect that maybe we went too deep during the transurethral resection, there is a suspicion of bladder perforation, or there is too much bleeding after the TUR bladder tumor, we do not put it in. Otherwise, we'll try to put it in every time. Now, if you look at JAMA, I think it is especially important for the residents who are on the audience. There is a JAMA article in 2018, and they basically looked at effect of intravesical installation of gemcitabine versus saline. They compared by installing gemcitabine or saline immediately after TURBT. This was done between 2008 and 2012. There are 406 patients. Median age was 66, about the same age where you see bladder tumor. And they put it in suspected low-grade tumor. Now, they suspected, but not everybody had low-grade tumor. Some had higher-grade tumor. And they randomized. They gave gemcitabine is given at 2 grams in 100 ml saline instilled under gravity immediately after the TURBT, and they left the medication for 1 hour and they drained it. And the comparator group was 205 patients, where instead of gemcitabine, they used saline. And this is what happens. So if you look at, if it's truly a low-grade tumor, the probability of recurrence is decreased by over 20% compared to saline. So this is gemcitabine, this is saline. If you use gemcitabine, you reduce the risk of recurrence of the bladder tumor, low-grade TA tumor, by close to 20%. So what is the advantage of gemcitabine over mitomycin? Number one, the cost is less. It is much less expensive in the United States, and I believe it will be the same true in Bangladesh. There is reduced side effect, less chemical cystitis, and it is readily available because medical oncologists use it all the time. So the main thing with the intravesical therapy will be low risk, non-muscle invasive bladder cancer have about a 40 to 50% risk of recurrence at 5 years. Single post-operative installation of chemotherapy, either mitomycin or gemcitabine, will reduce the risk of recurrence by 10 to 15%. Additional intravesical mitomycin is no longer, you don't need to put any more induction cycle for low-grade tumor. So that's the guideline statement. In a low-risk patient, a clinician should not administer induction intravesical therapy such as gemcitabine or mitomycin, just a single installation. What happens that if you have patients, let's say in the COVID time in Bangladesh or even in the United States, that you have patients where you can't do the TURBT because the OR is not available. So there is a study on that one. Can you put low-grade tumor on active surveillance? And the short answer is yes. So this is a study from Italy, and where they had close to 122 patients, and they put them on active surveillance. And they surveilled those patients for about 11 months. During that time, about 40% of the patient needed TURBT because they had hematuria, they have increase in size of the tumor. But on the other hand, 60% of the patients, 62% to be exact, remained on active surveillance. They didn't do anything on this patient. They continued to just do the cystoscopy and not do the TURBT. What that tells us, during COVID, if you have a low-grade papillary tumor, you can delay the treatment for a period of time without harming the patient. All right. So we'll go to the intermediate risk disease. And so the intermediate risk disease is multifocal low-grade tumor, or a solitary tumor which is more than 3 centimeters in size, or you resected a low-grade tumor and they come back within 1 year, recurrence within 1 year. That will be classified as the intermediate risk disease. What is the treatment again? You're going to do a complete resection of the bladder tumor. Again, the same thing. You send the top of the tumor separate, base of the tumor resect, send it separate. This is a meta-analysis of all of the chemotherapy which is used. I'll make it very shortly. And this is where they compared between BCG versus control as far as recurrence is concerned. This is the line. If you're on the left of the line, that means it favored BCG. BCG did a good job. And if you look at it, almost all studies showed that the BCG is much better in reducing the risk of recurrence than not doing any intravesical therapy. Same is true. If you use intravesical BCG, then all of these studies are on the left of the line. That means the BCG did a good job in reducing the risk of progression. Not as good a job as reducing risk of recurrence, but BCG is the only intravesical therapy which reduces the risk of progression also. So BCG is better than just TURBT alone. You look at this one, comparing BCG versus mitomycin C, and again, this is the line. A lot of the studies favored mitomycin, but a lot more studies favored BCG. That means BCG was better than mitomycin in reducing the risk of recurrence. So intravesical therapy, what do we say? Intravesical therapy for non-muscle invasive bladder cancer is associated with a decreased risk of bladder cancer recurrence compared to TURBT. BCG is more effective in reducing the risk of recurrence compared to other intravesical agents. BCG is the only currently used intravesical agent associated with decreased risk of progression. But BCG has the higher risk profile. They have more BCG-related side effects, cystitis, sepsis, etc. So for intermediate risk disease, mitomycin C may be the preferred agent in this group because the side effects are less. But if you look at the risk of recurrence, BCG will do as good a job, maybe even better, but the side effects are going to be a little more. Okay. I think we'll skip some of those slides. So what is the guideline statement for intravesical therapy for intermediate risk disease? So in an intermediate risk patient who completely responds to an induction course of intravesical chemotherapy. So let's say the patient had a complete response, a clinician may utilize maintenance therapy, may. It is not a must. Induction cycle, good response, you can use maintenance therapy. If you used instead of mitomycin, if you use BCG in an intermediate risk group patients who completely responds to intravesical BCG, a clinician should, this is a should, consider maintenance BCG for 1 year as tolerated. We'll go to the high risk non-muscle invasive bladder cancer, and I think I need to finish up. I'll finish within 5 minutes. So high risk disease, what is a high risk disease? So any grade 3 TA will be a high risk disease. That is fairly uncommon. So most of the high risk disease are T1, that means tumor going into the submucous of the bladder. Presence of any carcinoma in situ will be a high risk disease, or Ta-T1 with carcinoma in situ will all be considered high risk disease. So what is the first goal? Again, the first goal is to completely resect that tumor. Go down to the base, send the base separately to the pathologist for review of is it invading the muscle. Okay. The most important thing, if it's a high-risk disease, we always need to go back and resect the base of the tumor, usually after about 6 weeks. So this is one of the important guidelines on this patient, that any patient who has high-risk disease, you go back and resect the base of the tumor in 6 weeks to make sure that there is no evidence of invasion of the muscle. So a repeat resection of the bladder tumor is very important because it has diagnostic, prognostic, as well as therapeutic value. What is the diagnostic value? 30% of the patient who have high-risk disease, if you go back and resect the base of the tumor, have undiagnosed muscle invasive disease. It is therapeutic because if you do a repeat TUR, it is associated with improved response rate to intravesical BCG because you have making sure there is no residual tumor. And it is a prognostic value that if you find the patient have muscle invasive disease, you can put them on chemotherapy. So a repeat resection of the high-risk disease is critically important. I think we'll go to the next slide. So what is the important thing with high-risk disease? So high-risk disease, remember, there is clear-cut indication that for high-risk disease, you should use intravesical BCG therapy, not intravesical chemotherapy. And all patients with high-risk disease, they should have at least 6 weeks of induction cycle, and all of them should be followed by maintenance cycle as long as they can tolerate. And the maintenance could be up to 36 months. We do the maintenance at 3 months, 6 months, 12, 18, 24, and 36 months. So if the patient can tolerate, we should continue the maintenance cycle for up to 36 months. Quickly, we'll go over what do you do with BCG failure? When patient fails to respond to one course of BCG, the first thing we do, we use a second course of BCG, and about 50% of the patient might respond to a second course of BCG. Obviously, they have more side effects. One of the things we must talk to the patient, if the patient fails BCG, we should at least discuss with the patient about the cystectomy as a treatment option. That's one of the guideline statements where it says, in a patient fit for surgery with high-grade T1 disease, after a single course of induction intravesical BCG, a clinician should offer radical cystectomy. There are other studies, and one of them will quickly mention that, let's say the patient does not want to have a cystectomy. A lot of patients do not want to go for cystectomy because they do not have muscle invasive disease. One option is to use gemcitabine and docetaxel or paclitaxel, alternatively, 1 week gemcitabine, 1 week paclitaxel, and that will reduce the risk of, might reduce the risk of progression on those cases. I will go. There are other things which are available, either such as the patients who are BCG refractory, nanoparticle taxane, intravesical interferon, and the Keytruda, which is pembrolizumab. So this is my last slide. So this the guideline on non-muscle invasive bladder cancer provides a risk stratified clinical framework for its management. So we should all try to risk stratify non-muscle invasive bladder cancer. It is a dynamic process. It might be low risk in 2020. It might become intermediate risk in 2021 and might become high risk in 2022. So the same patient might change the risk stratification, to keep that in mind. Clinicians should use judgment in applying these guidelines to an individual patient and consider other factors. We're going to consider age of the patient, the comorbidities of the patient, and what does the patient really want. I think that is my last slide. Thank you. I think I finished it in 30 minutes.
Please unmute.
Thank you very much. Is it okay?
Yeah.
Yeah. Thank you very much, Professor Chaudhary, sir, for your nice elaborate presentation regarding the low and high grade of non-muscle invasive bladder cancer. Especially, this is the presentation is that regarding the low grade tumor, I think the single QRBT followed by single dose of inspiration therapy is sufficient in cases T1 disease. If it is the intermediate and high in between two, it is the question whether we can put the patient on intravesical chemotherapy or intravesical BCG therapy, inspiration, immunotherapy. Especially these two arms, it is more effective that BCG therapy is more effective than the intravesical schedule chemotherapy. That's why. But in high-grade tumor, if the high-grade tumor is T1, G3 associated carcinoma C2, if the patient put on BCG induction therapy followed by maintenance going on, if the cystoscopy found that there is recurrence tumor arises from during the follow-up cystoscopy, if the recurrent tumor is low grade, that is the good option. That the low grade tumor is not the disease progression, is the low grade disease. Then should go for the another course of BCG therapy for the patient to get benefit. But if the disease progression is high, then it is the question to go for scheduled or maintenance BCG therapy, or early cystectomy. I think early cystectomy is better option than the continuous of maintenance therapy because of its longer side effect. So thank you very much for your Chaudhary sir for your nice presentation. But I ask our audience or anybody ask any question, please put your question in the inbox. And Chaudhary sir try to answer your question.
So I think you summarized it very well, Dr. Ghulam Molla Chowdhury. I think that was a great summary. And I think we can always do the question and answer at the end if you want.
Yes, sir. Yes,
Because
sir.
I think there are other speakers, Dr. Rajiv Tipi and Dr. Ahmed are waiting, because I believe it is already 5:45, 3:44 in your time, right?
Yes, sir. After ending of the Maula sir, after ending of the all presentation, the who want to ask any question, please give your question in the chat box, mentioning the speaker's name or any panel of experts name. At the question answer session, we will discuss the question. Please, Maula sir, please go ahead.
Thank you very much. Next, we would like to call our second speaker, Professor Rajiv Tipi, and it is my great to introduce such a renowned urologist of our neighboring country, India, Professor Rajiv Tipi, man from Guwahati, Assam, India. And he completed his MBBS, MCH, and MS from urology, AIIMS, New Delhi. His current position as Professor and Head of the Department of Urology and Transplantation, Guwahati Medical College Hospital, Assam. And he, now the position of, there are three different positions he has held that in this time. That is, he is Honorable Secretary, Urological Society of India, Eastern Zone Chapter 2 times, Council Member of Urological Society of India, Honorary Secretary, Assam Urological Society, Honorable Treasurer, Association of Surgeons of Assam, Associate Editor, JASA, President, Assam Urological Society, Honorary Treasurer, Urological Society of India. Currently, he is the Honorable Secretary of Urological Society of India. And Professor Rajiv, he is such a learned and talented person. He has won a lot of awards. Especially, I mentioned 2 awards. One is Gold Medal for MCH Urology in New Delhi, Best Paper Award of Urological Society of India. And Professor Rajiv, he is also visiting professor, University of Minneapolis, USA. He has a lot of research paper published in both international journal about 57 and national journal about 51. And he wrote a chapter book like Nocturia, the book of test book of BPH. He is a MCI inspector of various center in urology, examiner of National Board of Examination, external examiner, MCH, urology of various center in India, member, Board of Education, Urological Society of India. Now I request Professor Rajiv to start his presentation on topics, muscle invasive bladder cancer, update and research guidelines. Thank you, Professor Rajiv.
Thank you, sir, for your introduction. And I am overwhelmed by the introduction which you have given about me. First of all, good afternoon, the President and Secretary, Bangladesh Association of Urological Surgeons, eminent faculty for the webinar today, senior members from Bangladesh Association of Urological Surgeons, urology trainee from Bangladesh, and viewers from other countries. I'm first of all thankful to the executive of Bangladesh Association of Urological Surgeons for inviting me and giving me an opportunity to be a part of this webinar. The topic assigned is muscle invasive bladder cancer. Bladder cancer is the, hello, can you hear me?
Yes.
Bladder cancer.
Yes, we can hear you.
Yeah, sorry. Bladder cancer, as all of you know, is the 6th most common occurring cancer in men. and the 17th most common cancer in women. As per Globocon, the incidence of bladder cancer is at the 12th position. And
Sir, we can see your screen, sir.
can
We
you
can
hear
see
me?
you. Yes, sir, we can hear, but we can't see your screen.
Oh, something happened. Let me go back. Something has happened, I think. Can I rejoin then?
Shiraz bhai, Shiraz bhai achen?
Yes.
We can see the screen of Rajiv, sir.
Can you see my projection? No.
There
No,
is
not
a
yet.
share screen button in your screen,
Share
green
screen.
color button. You need to put the share screen button at first.
Once more, I'm just going out. I cannot do anything here. Something happened. Just pardon me.
Rajiv, sir, could you hear me, sir?
স্যার মনে হয় লিভ করছেন, স্যারের মনে হয় নেটওয়ার্কের প্রবলেম হচ্ছে খুব সম্ভবত।
Can you call him and talk to him? Is there any way you can call him?
সিরাজ সাহেবকে হেল্প করতে পারে কিনা এখান থেকে?
স্যার যদি উনি শেয়ার করে থাকে প্রেজেন্টেশনটা আমাদের কাছে, দেন আমরা স্যার এখান থেকে শেয়ার করতে পারি স্যার।
No, I understand, but can you call him and see where he is, because we're not even.
তাহলে একটু বলেন,
Yes,
আমার
his
বলেন,
phone number.
if you can.
Can we do one thing? We can continue with the next speaker, and if you can manage, then we'll listen later. Why not
Tipu, sir.
start with the next speaker?
Secretary, sir, Tipu, sir. Can you call him or?
Professor Mola, sir. Professor Mola, sir. Can you hear me? I don't listen. Probably you are on mute. Mute. You're probably mute, right?
Tipu, sir, can you continue by Professor Mutar, sir?
we can start with Dr. Mutahar. If Dr. Rajiv can manage, then he will come later.
Better
Otherwise,
talk with Dr. Dipu to start the next person, Mutahammed. If we start
I
it,
think
Tipu sir, unmute your audio. Pause.
Hello. Yes, sir.
sir.
Assalamu alaikum, Lelin sir. I just talked with the Rajiv. He's wants 1 or 2 minutes more.
okay.
Okay.
Just a bit wait, sir.
Meantime, I have answered a lot of the chat questions.
Yes, yes. Okay.
So you could keep, reading those chat. And if you file more questions, I'll try to answer them.
Can we start the next speaker? You will. Okay. Just by this time, you try in your laptop. If not possible, I send a email ID in your WhatsApp. If not possible from your laptop, you send the presentation through the mail to that, so that we can control it from here. Okay. Just let me know. Okay, Mala sir.
Okay, we'll try to start the next.
Mala sir, yes, we can start the next.
We are fortunate that we hear from Professor Mutar Ahmed earlier, Professor Rajiv. Okay, thank you very much, Dr. Mutahid. I feel proud to honor and to enhance such a delighted speaker. He is the son of this soil. Dr. Mutar Ahmed, designated as the Assistant Professor of Seton Hall University Medical School, New York, New Jersey. He is also a clinical associate professor, Rutgers University Medical School, New York, New Jersey. He is a director, Center for Bladder Cancer at Hackensack UMC, Hackensack, New Jersey. He is a renowned laparoscopic and robotic surgeon, and he achieved a lot of awards and honor. I have mentioned one of them is Castle Connolly Regional Top Urologist. He was last 2013 to 2017, New Jersey Inside Magazine Top Cancer Doctor. Congratulations. Bladder County Top Doctor 2014. New York Metro Area Top Doctor 2040. Pfizer Scholar 2003. Gerald P. Murphy Award, AUA Prostate Research 2003. Outstanding American Laparoscopic Fellow 2003. I know that Dr. Mutahir, he is a very enthusiastic person and he is a master of both robotic and laparoscopy. And he conducted many AUA induction sessions in Bangladesh. Now I request Professor Mutar Hussain to start his presentation topics on surgical management, TURBT to laparoscopic cystectomy. Thank you very much. Good morning, Dr. Mutahir. Please start your presentation.
Okay. Can you hear me now? Thank you, Dr. Molla, for this generous introduction. And I'd like to say good morning to everyone, but good afternoon for you all. And hopefully everyone is safe. Okay, so we'll just quickly go ahead and start. So what I would like to do is I'll make my presentation a little bit exciting. Hopefully it works because there is some video session that I'll go in between. And Dr. Chowdhury really gave you a nice summary of non-muscle invasive, and I'm sure Dr. Rajiv would give you a nice muscle invasive, but this is more of a technical talk, my talk. And Dr. Deepu actually asked me to discuss about en-bloc TURBT. So I asked one of my residents to actually prepare the talk. So he helped me prepare the talk. His name is Nathan Cheng. So I want to give him some credit for helping me with the presentation. Okay, so I was told that I should start with some case presentation, and that's how my talk will go. So we'll start with a quick case presentation. So we have a 62-year-old male with gross hematuria. It's intermittent, and it started after taking aspirin, which was recommended by his primary care doctor for family history of MI. So we have a 62-year-old man who's a smoker, who has intermittent gross hematuria. We're all discussing bladder cancer here, so we have to rule that out. In that case, this patient showed up in our office. So of course we have an ultrasound available in our office. So we did an ultrasound, and that showed a 3 centimeter bladder mass. And at that point, cytology was sent. And in that case, most of our residents will say, okay, what should we do next, right? And Dr. Chaudhary talked about it before. So we have to get a CAT scan, a CT scan with CT urogram. And of course, the patient have to have a cystoscopy with TURBT or etc. So cytology, CT scan, which include the upper tract, so you could get a CT urogram, and a cystoscopy. That's a basic workup for these kind of cases. So CT urogram was done. Patient was scheduled for cystoscopy with TURBT. So here is the question: what type of TURBT you may consider? So I'm pretty sure you all know that now there is a new buzz going on, en-bloc TURBT. Audience, you heard of that, right? En-bloc TURBT. So I'm going to cover that a bit in my discussion because that was requested by the host. So I'll go into en-bloc TURBT, what is it and how is it done? But let me just give you a little summary of what this patient can get. So medium size tumor, 1 to 3 centimeter, en-bloc TURBT is a good choice. Above that, more difficult, can be done in stages. Standard TURBT, as Dr. Chaudhary mentioned, that take a deep resection at the tumor bed and level it as deep, separate from rest of the specimen. It's okay to see bit of fat. You know, a lot of time, even our senior doctor, they're afraid to take a deep bite because they think they will perforate. But a micro perforation, visualization of fat is okay. You want to have a good specimen. So that's very important, as Dr. Chaudhary mentioned, and I'm stretching that here again. And it's okay to do CBI. In my experience, what I do when I do a deep bite, I'll fulgurate everything, but I'll start a CBI for first 1 to 2 hours. Why? Because the time of the extubation, when the patient is getting extubated, that's the time they do a lot of bucking. And when they do a lot of bucking, by the time patient go to the recovery room, you have gross hematuria, you have clots. So if you can put the patient on CBI for that a half an hour to an hour, that will save you a headache later with a clot catheter. Must have good pathology lab. We train pathologists, high grade, low grade, they have to be able to distinguish that because grade is destiny when it comes to bladder cancer. And second question is it muscle invasive or muscle or not? That is very important. So when we do the TURBT or en-bloc TURBT, we have to have muscle present, especially if it is a high-grade tumor. As Dr. Chaudhary mentioned, there is a big difference between muscularis mucosa, which is T1, as he mentioned, and muscularis propria. Muscularis propria is the real muscle. So a lot of time, even in the United States, I'll give you a quick story. I get a lot of referral to do patient for cystectomy, right? That's one of the things that I do a lot. So patient will come in and I'm looking at the path, and in the pathology is actually, it says invasive carcinoma, high grade, but if you read deeper, it says it's invading into muscularis mucosa, but the real muscle seen and it's not in the real muscle. But because the word is written as invasive carcinoma, the patient, the original urologist automatically thinks that it's a true muscle invasive. So that's very important to distinguish between T1 versus T2. if good pathologist is not available in your district level, this is a very important point that I'm putting in on the slide, because we need a good recording of the pathology specimen. So if you don't have a good pathologist in your district level, my humble suggestion would be put the specimen in the formalin, level it at the deep and rest of the tumor, and bring it to Dhaka. Bring it to Dhaka to one of your good pathology friend, and let them review these pathology and prepare the slide and give you a correct answer. Because you will be doing really disservice to the patient just by doing a TURBT without being able to distinguish if it is a high grade, if it is low grade, if it is muscle invasive or muscle invasive not. That's very important. So please try to, it's just as important to have a good pathologist as well as good resectionist. So what is en-bloc TURBT and why we are considering these en-bloc TURBT nowadays, all of a sudden? Okay, so the quality of initial TURBT non-muscle invasive bladder cancer strongly determines patient's prognosis, right? And lifetime treatment and cost. Bladder cancer is really an expensive, it's #1 most expensive Medicare DRG. Dr. Chowdhury will tell you, in the United States, that's the #1 most expensive disease because it needs a lifetime follow-up essentially. It is thought that en-bloc resection improves the quality over conventional resection of the bladder tumor. So disadvantages to the conventional TURBT. You have a high rate, up to 60% of missing detrusor muscle. We get that in the United States all the time. We don't have a deep resection of the muscle. So this study has shown that if you don't have a muscle on the specimen and you have a high-grade tumor, it impacts the recurrence-free survival. So TURBT does piecemeal resection. It causes a lot of charring of the specimen, leading to poor pathologic analysis. And malignant cell scatter and potential seeding. So how to perform en-bloc TURBT? For tumor less than 3 centimeter, it's very feasible. For tumor greater than 3 centimeter, may not be as feasible because it will get stuck in the resectoscope. Monopolar, bipolar electrocautery loop can be used. Holmium laser, there are other technologies coming out that are burst energy. You could easily see it in the internet, those other type of technology. And you start 1 centimeter away from the tumor on a normal bladder mucosa and use coagulation to mark out the circumference around the tumor, cut down to the muscle fiber, then stay in that plane and undermine the tumor. Flash firing is not a continuous electricity, but it's a burst of energy that you could do it with a bipolar or monopolar, multiple small movement instead of one continuous swipe. And while conventional TURBT, the cutting is recommended by pulling the loop toward the scope or towards you. But en-bloc TURBT at some location, you may do it opposite. You push the loop away from you, which is a no-no. Our professor tells you that don't ever push the loop away from you because you could perforate. But in this case, you could do that because you are going to do it very controlled manner. I'm going to show you a quick video after I just talk about, the why is this important and what the studies has shown. So basically, this is a study from China, retrospective study of 90 patients. He did 40 en-bloc and 50 conventional, and he did tumor even up to greater than 2 centimeter or 3 centimeter, and the follow-up cystoscopy and the result were analyzed. And you could see that there was not any significant difference in terms of operative time, but he had 100% detrusor muscle in en-bloc TURBT versus only 70% in conventional TURBT. So this is a big difference, right? Almost a 30% difference of getting a real muscle versus not getting a real muscle. And there was no difference in catheter or hospitalization and no difference in reoccurrence, but this was a short-term study. So this is how pathology looks like. So you see the first slide is a lot of charring. That's from conventional TURBT. And this is from en bloc, looks nice and clean with preservation of the lamina propria and muscularis propria. And this is another study comparing safety and efficacy of the resection, conventional versus the en bloc. And here he did a meta-analysis of 2,651 patients with about 1,300 en bloc and 1,200 conventional. And here, what we saw is perioperative hospitalization and catheter times were decreased. Decrease in complication. However, no statistical difference was seen in detrusor muscle in specimen. However, it was more in en bloc, 94% versus 86%. And oncologic outcome, 24 months, there was no difference. But, sorry, 12 months, no difference, but 24 months, there was a less reoccurrence in en bloc versus the conventional. And 36 months, no, there was no difference. So the bottom line is, it is feasible to do for tumor 3 centimeter or less, although some studies have shown even more. Safe, no difference in operative time, improved complication rate, and decreased hospitalization stay. Better detrusor muscle yield, which is very important, and better 2 years recurrence rate. So it is something to consider, but it has to be done in a smaller tumor than a large one. The large one, you could take it down and then do the base. And I'm going to show you a quick video. Let me see if I can share this. There you go. See, so that's how you're done. You take, so you take about a centimeter away from the stalk, and you mark it up with, this is a Collins knife, but you can easily use a TURBT knife, and you could bend that loop and make it a sharp point. We have all done that, and that becomes like a Collins knife. We also call this an airplane. But anyhow, 1 centimeter away from the stalk, and you mark it up. And then the next step is you take a deeper swipe. And here we're doing it toward us, but you could also do it, away from us. So you get into that plane of the muscle and gently resect it off, but in a burst energy, not a continuous energy. You see, you're digging into the muscle layer, so you know where the muscularis layer is, and you stay on that plane, and you continuously dissect and resect it off in entire en bloc tumor. Now, obviously, if it is a 5-6 centimeter, you cannot do this. You have to resect the tumor, and then the base may be too wide, and it will not be feasible to do it, but a tumor under 3 centimeter easily can be done. And here, you see the muscle, and you kind of use the head of the loop to push the specimen away, and you'll see it will separate very shortly. So kind of nudging it off, and you could clearly see the muscle. So you know you got into the muscle level, and there you go, it's off. So that's kind of neat way of doing this thing. Let me go back to my slide. All right. So that's the bottom line, and that's the take-home points from en bloc TURBT. Hopefully this gives you some idea, but you could definitely look it up more in the YouTube and other scientific paper. So this patient had conventional TURBT. So as I mentioned, and he had a 3 centimeter bladder mass, and we sent cytology. Cytology was positive. His CT urogram confirmed the 3 centimeter mass. I like to get my CT urogram before I do the TURBT because it does not mess the area around, and you get a true picture of any kind of mets. Otherwise, you see a lot of fluid and this and that if you do a CAT scan 2-3 weeks after the TURBT. So he already had a CT urogram, no metastasis, 3 centimeter bladder mass. So we took him for a TURBT, and he had a conventional TURBT. And what it showed high grade, but unfortunately no proper muscle was seen in the specimen. So in this case, we have to take this gentleman back for a repeat TURBT, because if there is no muscle seen in the specimen, you cannot make any comment about is it muscle invasive or not muscle invasive. It's a high-grade tumor, so this is a high risk, as Dr. mentioned. So we must see the muscle. So I said, what's next? We're going to take him back and must go back and do the resection of the bed and get muscle. The second TURBT was done. Muscle seen in this time, but not involved. So essentially, this was a T1 high-grade disease. So what's next? As Dr. Chaudhary mentioned, in this case, patient should get BCG, and he got 6 weeks. You normally wait 4 weeks after the BCG is completed, and you take him back to the OR, and you can do, if any areas look suspicious, you should do a biopsy. If things look completely normal and clinical judgment, you may be able to avoid the biopsy in that case. However, any suspicious areas should be biopsied, and patient should be checked for cytology, and then patient should be placed on maintenance BCG, as Dr. Chaudhary mentioned. So this patient, after his second cycle of maintenance BCG, we took him back, and this time he has a reoccurrence, a 3.5 centimeter broad-based sessile mass. So in this case, we have to resect this. So in this case, here an en-bloc TURBT done with a deep resection. Path came back high grade, and this time muscle invasive. So now he has progressed to T2 disease. So in this case, you have to restage him, right? So you have to do repeat CT urogram, and metastatic workup came back negative, except for few 1 centimeter lymph node on the right and left external iliac area. So what do you think? Is this significant? I'm just asking a rhetorical question. So usually a 1 centimeter after BCG, after TURBT, probably this is not a METS, but this is something you should consider, that there is a possibility this could be a METS. So any significant this, we already talked about it. If concerned, you can get PET CT. I'm really against getting PET CT for any urologic cancer, but bladder cancer sometimes can be helpful if the CT urogram is indeterminate for metastatic workup. So what's next? So this patient had CAT scan, and those lymph nodes didn't light up, and the rest of the metastatic workup is negative, and he has T2 high-grade tumor of the bladder. So in US right now, it's pretty much the standard is the next step is patient should be referred to an oncologist, and we should work as a team, and the patient should get a neoadjuvant chemo, and we set up a schedule for him that he will do his chemo, either 4 cycle or 6 cycle, and then wait 4 weeks, and then we'll do radical cystectomy. So that is the normal standard of care right now in the US. So we should discuss with patient and the spouse of the patient, radical cystectomy while he is getting the chemo, various urinary diversion, ileal conduit, neobladder, continent pouch, Vienna pouch. He is only 62, very good health. So he is obviously a good candidate for neobladder. So we should at least present that to him and try to make it that he can choose that avenue, because I think 62-year-old healthy individual should get a neobladder as long as he understands all the complication and all the learning associated with it. So he will complete his chemo, and then 4 to 6 weeks rest, and then we do his surgery. So important consideration when we do surgery and when we're thinking about surgery is patient must, in this case, get extended lymph node dissection, which is at least you have to go up to common iliac, and a lymph node dissection that should at least have 12 nodes or more. I'll show you our data is like at least we have 25 or more lymph nodes on average, and must include space of Marseille, which is the nodes that are behind the iliac artery and behind the iliac vein. Most surgeons are afraid of that area, but a lot of time that's where the nodes are being left. And those nodes come back positive year, 2 years later after the cystectomy. So an extended full lymph node dissection in cystectomy is very important and very important to keep in your mind. Discuss with patient how to manage the neobladder if we're going to choose the neobladder. And I think this patient should be encouraged to pick the neobladder. And complication associated with it, but reward is tremendous because you will avoid bag and you will avoid continuous expense associated with the bag. Kegel exercise is very important as a preoperative instruction. Nerve sparing, we should discuss with him. He's 62, what's his sexual function? And we should tell the patient that you have a chance of being incontinence, although that is not that significant, but nighttime incontinence is a significant problem on a neobladder. Patient will, at least 15-20% of the patient will have nighttime leaking. But a lot of our patients, they don't mind nighttime leaking. They rather not wear a bag, not able to urinate normally than dealing with a little bit of nighttime leaking. But patient has to be told. And the other important factor, patient has to be told that at some point in the future, 3, 4, 5 years, he may need to do self-catheterization because some reason these bladder will expand to a tremendous amount and they can start to get a residual hydro or compensation of renal function. In that case, he has to be ready to do self-cat. If those conditions are met, definitely this patient can get a neobladder. And we also have to talk to him about the other option, ileal conduit and continent pouch as well. So something else to consider that we do a lot in the US right now is enhanced recovery after surgery protocol. I'm pretty sure you heard of this. This is especially done with any patient get bowel surgery. And perioperative, we put patient in a high protein drink. In America, we call them Ensure or Boost. In Bangladesh, you have Horlicks. I'm pretty sure it's full of proteins. So patients should be put on Horlicks, 1 glass every day, 4 weeks prior to surgery. This is very important because these patients are getting chemo, they're weak, they have to be optimized. Fluid, high sugar content fluid, Gatorade in here. I don't know what in Bangladesh, maybe Ruafza. Ruafza is good, if they don't have a diabetes. 24 hours prior to surgery and up to 2 hours prior to surgery. So patient can have a clear liquid up to 2 hours prior to surgery. So these are ERAS protocol and no mechanical bowel prep unless using large bowel. Or when I do a neobladder, I may just give them 1 bottle of Mexitrate just to clean them out a little bit. But no need for mechanical bowel prep, absolutely not. Perioperative and intraoperative post-op consideration. Part of the ERAS, this is all part of the ERAS. Second or third generation cephalosporin, 2 gram or dose adjusted according to patient's weight. And additional dose if surgery is lasting for more than 4 hours. And you continue at least 3 dosage post-op, no more. Right before going into surgery, patients should get Celebrex, Tylenol, gabapentin, and Entereg. These all helps with the bowel mobilization and avoid ileus. Now, avoid narcotics. Post-op, we have no order for narcotics. Patient will get Tylenol, which is Ofenib, and Toradol, but no narcotic at all. None of our cystectomy anymore gets narcotic. We don't even have a order for it. No NG tube or only for 24 to 48 hours. If you're doing somebody with radiation or radiation failure cystectomy, I may keep it for 48 hours. Chewing gum, very important, very small little things, but it makes a big difference in terms of recovery after cystectomy. Clears on post-op day 1 and then advance the diet to regular as tolerated. Start diet early, ambulate early, must push the patient. Patient will want to baby themselves. They will think, oh, I have pain, I have this. No, obviously we do robotics, so they have less pain. But even in open cystectomy, if you condition the patient correctly, they will move next day. And this is a goal. You have to tell the patient that we're gonna get you out of bed next day. You cannot cry, because that's for your own good. Now here I have few videos. I'm gonna start off with one, and if we have time, we could go with another one. Now, since we talked about en bloc, TURBT, I'm going to show you in the cystectomy case, the most modern approach that we use, more minimal invasive compared to just the robotic surgery. So we started doing single port cystectomy. So I'm going to show you a quick video of single port cystectomy on a male. And if we have time, we'll go to the female as well. There you go. So this is a single port. So you could see one robotic port and one assistant port. And this assistant port is where the stoma, this patient-ready ileal conduit, where the stoma will come out from. So you have no other extra port. So this was a 64-year-old man. And here we started with the finding the ureter and the lymph node dissection. So here's a iliac artery. You could see that we're dissecting the node off and we're going more distally, and you could clearly see it. So that's the iliac vein, and you see how we're retracting the artery and we get behind the artery to get the rest of the nodes. Now here we are working on the distal ureter, putting a clip. I mean, this video is going to go very quick. It's only 3 minutes long. And host, if you think I'm going over, please let me know. So we dissecting the ureter off. This is a left ureter, and now we did the right ureter already, and here we're getting between the rectum and the bladder, and he was little adherent in this area, but you could clearly see the seminal vesicle. So the rectum is down here, bladder is up, and here going toward the apex of the prostate, freeing up the nerve, and now we drop the bladder. I mean, these videos are available in my YouTube channel and in a longer length, so you could see them more detail here. We're freeing up the urethra. Now, careful attention to any kind of spillage. So we put a clip and we stop any kind of spillage from happening. Here we're doing the bowel reconstruction. You could see all intercorporeal, nothing outside. Use a lot of state sutures to hold the bowel, and you'll see the bowel is being isolated. And once the bowel gets isolated, we'll use the stapler. This is a handheld stapler, Covidient or Ethicon. And my assistant is putting the stapler through that assistant port that will eventually become the stoma port. So here we are basically isolating the bowel, bringing the bowel together, and we'll do the anastomosis of the bowel, re-anastomosis. Here, the conduit piece is right here. And using the state sutures to bring the bowel and line them up is very important when you do intercorporeal cystectomy and diversion. So here, doing the anastomosis. And by the way, we also have robotic stapler. In the next video, you'll see, sorry, not on the next video. In different video, you'll see it. Here, the single port robot does not have robotic stapler. So this is a manual stapler that is done. So here, preparing the ureter for a Wallace anastomosis, nice wide spatulation, and closing the back wall of the ureter. And then we'll bring the ureter to the bowel and connect each side. Very systematic, no skipping of steps. Everything is visualized and visible, and the robot is great in that case, we think. And anything is possible if you can master the robot with time. So here, doing the basically Wallace anastomosis. This is one side of the ureter. The back side of the ureter is already put together. Both right and left ureter is stented with double J stent. And we'll take the stent out about 10 days later. Sometimes it requires a cystoscopy through the conduit or through the neobladder to remove the stent. Here, the anastomosis is being completed. And what we'll do, we'll bring the stoma, and one incision and only the other assistant incision is for the stoma. So that's pretty neat. And can we show the second video? We have time? I think we have time. Okay. So here is a Here's a female neobladder, cystectomy with a neobladder. Again, this is neat.
মাওলা স্যার আনমিউট করেন আপনারটা
Visualization of the ureter, doing the lymph node, but
আনমিউট করেন আপনারটা মিউট করা আছে
we actually do the bowel
Yes.
work through the
No.
vagina, stapling through the vagina. So here, removing the ovary and block, everything goes out and block. But I'm going to quickly advance the video to show you that part.
Dr. Mutahar, please, Dr. Mutahar, can you hear me?
Yes.
Yes, sir. But we are running short of time because there
All
is.
right. So here you go. This is the stapling through the vagina.
Acha, acha.
You see, the staple is coming right to the vagina and doing the bowel work. And I'll just show you an outside picture, how it looks like, and then we'll move on.
I think your presentation.
There you go. You see, this is how a cystectomy or a neobladder on a female looks like. That's another picture.
I think it is very amazing because anybody want to see later on, they can go for YouTube or take the collection of video from you later on to see.
Right. And I also have an extended lymph node, but you could see it in the YouTube video. I'm not going to show it here because of the saving of time. So I just want to show you that this is our comparison of operative and post-operative data. This is a prospective data. So this is a real, it's almost like, it's not randomized, but close to being a randomized. So here is a multi-port cystectomy and single port cystectomy. We started collecting these data just to compare the single port versus multi-port. On the single port, the length of stay was 6 days, and on the multi-port, the length of stay was 6 days, and on the single port, the length of stay is 4 days. Well, I think it's too early to tell that this is far better, the single port, but at least it's not any worse than the multi-port, and the patients are going home earlier. And oncologic, the overall lymph node is we're getting about 25 to 30 lymph nodes on average. So this is we're not cutting short on oncologic factor as well. So thank you. Any thoughts? I'll take a question. And keep COVID in mind when doing surgery. Please use proper PPE. We have to operate on this patient, and sometimes we think the patient may not have COVID, but he or she may have COVID. So you have to treat everybody like they have COVID. So please wear appropriate PPE, use mask, N95, especially if you're going to do TURBT, where you have a lot of smoke, a lot of aerosol. You should use suction device. So make sure a lot of smokes are not in the environment. Although very little virus load is seen in the urine, just to make it clear. Thank you.
Thank you very much, Dr. Mutahar, for your nice presentation regarding the, I think, TURBT to up to radical cystectomy. And you have shown the, I think, en bloc radical TURBT, but you know that we have already started the en bloc resection during TURBT. The same protocol we are following this way, but one amazing thing is that while you go for enucleation or en bloc resection, then you can directly see the muscle layer.
Yes.
Yeah, that is the most important thing, that when you go for en bloc TURBT, then you are ensured that you bring the muscle layer. That is the then muscle could be seen by en bloc TURBT. But problem is that less than 3 centimeter TURBT en bloc is feasible. When it is more than that, then what we'll do? But I face one problem. Tumor size is more than 3.5 centimeter. We did the en bloc TURBT, but we cannot bring the total specimen through the sheet.
Yeah.
And we put the rigid biopsy process and grab the mass and bring it out along with the receptoscope.
Yes, that is one of the issues. So what you could do, you could remove part of the tumor by doing a standard TURBT, and then take the base with the en bloc.
Yeah, thank you very much for your.
Thank you.
But we are waiting our previous presenter, Dr. Rajiv TP. He is waiting for that. Now I invite Dr. Rajiv TP to start his presentation once again. Thank you. Can you hear me, sir?
Yes.
Yeah, I think you just go on.
Now, can you see the slide?
Yes, sir. We can see.
Now it is full screen.
Yeah, we can see Dr. Rajiv.
Yeah, we can see.
Yes, sir, we can see.
I do apology to everyone for the hitch, what has happened, and the loss of time because of it. I extend my thanks to the executive of BOUS for giving me an opportunity to speak on a subject on muscle invasive bladder cancer. Can the next slide? So as all of you know, bladder cancer is the most common sixth most common cancer occurring in men, and it is the 17th most common cancer in females. And as per Globocon 2018, it is at the 12th position. Next. Can you move the slide? Next slide. Next slide, please. Next. Next. So approximately 9 out of 10 patients of bladder cancers are diagnosed after the age of 55, and nearly 75% bladder cancers occurs in men. And to highlight, it is one of the costliest cancers in terms of treatment. Next slide. About 20 to 30% of patients at the time of initial presentation or diagnosis have muscle invasive bladder cancer. Muscle invasive bladder cancer is supposed to be a highly lethal entity. The fact being the mortality associated with it within a 2-year period is around 85% in untreated cases. Further, non-local regional relapses reflect the presence of micrometastatic disease at the time of diagnosis and treatment. Next slide. These are the various etiological factors which have been highlighted by my earlier speakers for the occurrence of bladder cancer. Next slide. Next. So of the bladder cancers, more than 90% of them are transitional cell carcinomas. Next. Next slide. These all of you know that they present commonly with total gross painless hematuria of clots, and there can be irritative symptoms like frequency, urgency, and dysuria when it is associated with carcinoma in situ. Next slide. Next slide. Bladder mass detected by any imaging modality should undergo cystoscopy, resection biopsy, and the tissue should be sent for histopathology. This is basically to establish the diagnosis and the muscle invasiveness of the disease and presence of associated CIS. Next slide. If bladder tumor is visualized unequivocally by CT, MRI, or ultrasonogram, diagnostic cystoscopy can be omitted, and one can proceed directly for TUR bladder resection or debulking and send the tissue for histopathological examination to establish the diagnosis. Next slide. Cystoscopy and biopsy, as all of you know, is the gold standard in the evaluation, and there are certain enhanced cystoscopic techniques which can be further added on, because small papillary tumors and more than 30% of CIS are overlooked on standard cystoscopy, which can be identified by fluorescent cystoscopy. Narrowband imaging is an optical imaging enhancement technology which will improve the visibility of blood vessels which are inherent to the neoplastic process. Next slide. Optical coherence tomography, it's a real-time imaging technology using infrared light, and this provides a cross-sectional images of the biologic tissues. Confocal laser endomicroscopy, herein a fluorescent dye is administered and it is assessed under a low power laser to scan the tissue section of interest below the surface. Next slide. Enhanced cystoscopic techniques are now used as techniques to be considered for improving the detection rate and for ensuring a more complete TUR. This is AUA. There are various urinary tests performed earlier, but this has failed to replace cystoscopy. Next slide. Next slide. No, previous slide, please. So I'm dealing with earlier speaker, Professor Chowdhury, has spoken about the non-muscle invasive bladder cancer. So I will be concentrating my talk on the muscle invasive one, that is the T2, T3 tumors. Among the T2 is further divided into T2A and T2B, and T3 is further divided into T3A and T3B. Next slide. Next. So this is as per the recent AJCC 8th edition. In the earlier AJCC 7th edition, N1, N2, and 3 tumors were involved in stage 4, but according to the recent one, N1 tumors, that is T1 to T4A, N1 tumors are grouped as stage 3A, and N2 or N3 are grouped under stage 3B. Next slide. Pathologic analysis of the depth of invasion of the tumor on TUR, bimanual examination under anesthesia, contrast enhanced CT of abdomen and pelvis with evaluation of the upper tract. This is mandatory for assessing the disease and the extent of the disease prior to radical cystectomy. Next slide. Multi-detector CT scan has a high sensitivity and specificity for local staging of the cancer, because in majority of the cases, the patient has undergone a TUR debulking of the disease. So one has to wait for a period of minimum 2 weeks prior to going for a CT scan. This is just to minimize the inflammatory artifact which may be mistaken for a T3 disease. Next slide. Magnetic resonance imaging, its role, it's more accurate than CT in detecting local tumor stage. And there are certain advancements in MRI, like incorporation of 3 Tesla magnets, DC and DWI. This has in fact improved the ability to locally differentiate T-staging of tumors compared with CT. Next slide. Now this is a study which has compared CT and magnetic resonance imaging in the primary staging of bladder cancer as compared to final histology. They have concluded that MRI is better at staging extravesical disease, whereas CT is better at staging localized disease. Next slide. In short, what is the utility of imaging? It is basically to assess the extent of local tumor invasion, tumor spread to the lymph nodes, tumor spread to the upper urinary tract and other distant organs. Next slide. Pelvic nodes more than 8 mm and abdominal nodes are more than 10 mm in max short axis diameter on CT or MRI is regarded as pathologically significant. Next slide. What about PET-CT? PET-CT has got limited role in local staging of bladder cancer. It is very highly sensitive and highly specific in detecting nodal metastasis, but still not recommended by any guideline as a primary imaging modality in bladder cancer. Next slide. So this is a recommendation of EAU. Confirmed MIBC, use computed tomography of the chest, abdomen and pelvis as optimal form of staging. This has got a strong recommendation. CT urography for upper tract evaluation and for staging, strong recommendation. Use of MR urography when CT urography is contraindicated is strongly recommended. And use of CT to diagnose pulmonary metastasis, again strongly recommended. Next slide. Do not offer sexual preserving radical cystectomy to men as standard therapy for muscle invasive bladder cancer, strong recommendation. Offer sexual preserving techniques to men motivated to preserve the sexual function, since the majority will benefit, as a strong recommendation. And this should be done only in those selected cases where the disease is organ confined, absence of any kind of tumor at the level of prostate, prostatic urethra or bladder neck, again has a strong recommendation. Next slide. Offering neoadjuvant chemotherapy for T2, T4A, N0, M0 bladder cancer, especially with cisplatin-based combination therapy, strongly recommended. Do not offer preoperative radiotherapy when subsequent radical cystectomy with urinary diversion is planned, again as a strong recommendation. Next slide. So the standard modality of treatment is radical cystectomy plus bilateral pelvic node dissection with neoadjuvant chemotherapy. Now it is the gold standard therapy for muscle invasive bladder cancer. Time from initial diagnosis to cystectomy affects oncologic outcome if the delay from diagnosis to definitive treatment protocol is delayed by more than 12 weeks. Next slide. So indication for radical cystectomy, a muscle invasive bladder cancer that is clinically T2, T4A, N0, M0 bladder malignancy. In certain settings of non-muscle invasive bladder cancer also, radical cystectomy is indicated, which has been highlighted by my earlier speaker. Next slide. So radical cystectomy, what are the types? One is the standard type of radical cystectomy, which I told you earlier. Next thing is the sexual preserving one. Next slide. So what are the sexual preserving radical cystectomies? One is prostate sparing cystectomy. Another thing is seminal vesicle sparing cystectomy. Next slide. nerve sparing cystectomy, or capsule sparing cystectomy. Next slide. So this is an article on which compared the oncological and functional outcomes of sexual function preserving cystectomy compared with standard radical cystectomy in men. They have concluded that no difference is found in comparative studies reporting oncological outcomes. Postoperative potency rate significantly better in those sexually preserving one. Overall quality of life is moderately better in sexually preserving cystectomy, but the patients has to be highly selective, counseled, and closely monitored in this setting. Next slide. Oncologic outcomes following radical cystectomy. First of all, it is the pathologic tumor stage. Secondly, the presence of nodal metastasis, which is supposed to be the strongest predictor for recurrence and survival. Pathological T0 or residual non-invasive disease is associated with a 5-year cancer-specific survival rate approximately to the tune of 90%. But in case of pathological T2 tumors, 5-year disease-specific survival drops to 70 to 80%. Next slide. If it is T3, patients fare significantly poorer, where the 5-year disease-specific survival drops to 40 to 50%. If there is involvement of lymph nodes, as I've told you, it is the single greatest predictor of survival. There again, in node-positive cases are associated with a poorer prognosis. 5-year disease-specific survival drops to 20 to 35%. Next slide. So cystectomy not to be performed when? Number one, unresectable lymph node metastasis because of its bulkiness or the proximal extent above the common iliac vessels. When there is extensive periurethral disease, or when the bladder with growth is totally fixed to the pelvic side wall, or when there is significant invasion to the rectosigmoid canal. Next slide. EAU ESMO consensus statements on management of advanced bladder cancer. They have highlighted that chemoradiation to improve local control in cases of inoperable locally advanced tumor. So in patients with clinical T4 or clinical N+ disease, radical chemoradiation to be offered as a palliative mode rather than with a curative intent. Next slide. What are the different types of urinary diversion? Already it has been highlighted by Dr. Mukta. One is continent conduit urinary diversion, continent cutaneous reservoir, or orthotopic neobladder. These are the 3 types of urinary diversions which have been commonly advocated in case associated with radical cystectomy. Next slide. So the pelvic lymphadenectomy, again already shown, there are 3 levels, level 1, level 2, level 3. Level 1 is the standard and the most commonly followed procedure, where the lymph node packet is removed, extending cephalad up to the bifurcation of the common iliac, laterally up to the laterally up to the genitofemoral nerve, and medially up to the level of the ureter. Next slide. So extended template level 2, they have found that if the lymph node packet is extended up to the aortic bifurcation, there can be an improvement in the recurrence in the lymph node, because it has been found that in some 10 to 15% cases, there can be involvement in the lymph node packet up to the level of the common aortic bifurcation. Super extended template, that is level 3, that is the template up to the level of the inferior mesenteric artery, but it has been found that there is no added advantage when you do a very super extended template. But there is no general literature till now regarding these 3, and still basically the standard template protocol is followed, and in most studies the number should range between 10 to 16. Next slide. So extended versus lymph node dissection, limited lymph node dissection, bladder cancer patients undergoing radical cystectomy. This is a prospective randomized trial. This has been published in April 2019. They have concluded that extended lymph node dissection failed to show a significant advantage over limited lymph node dissection, that is the standard lymphadenectomy, in regard to recurrence-free survival, cancer-specific survival, and overall survival. Next slide. So these are the various surgical complications, which again, one is wound infection, prolonged ileus. These are the 2 early complications. And among the late complications, the most common is acute pyelonephritis, then it can be conduit bleeding or metabolic acidosis associated with the bowel used for diversion. Next slide. So what could be the recurrence following the surgery? Local recurrence can be to the tune of 6 to 9% within the soft tissue field of exenteration. Distant recurrence can be to the tune of 20 to 35%, that is outside the pelvis. And there can be a recurrence in the retained portion of the urethra in 6 to 10% of cases. Next slide. So recurrence usually occurs within the first 2 years. And what are the risks? Factors for recurrence. One is presence of a P-T3, T4 disease. Secondly, positive or malignant lymph nodes in the lymph. Three risk groups for failure are, it can be divided into 3 categories: low risk, intermediate risk, and high risk. Low risk are those cases which are less than P-T3 disease. Intermediate one, P-T3, T4 disease, but with negative margins. And when you have more than 10 lymph nodes in the lymph node packet sent for assessment. High risk group is P-T3, T4 disease, but there is a positive margin and only 10 lymph nodes have been found in the lymph node packet sent for histopathological evaluation. Next slide. So neoadjuvant therapy for muscle invasive bladder cancer, why? Because it has been found that more than 50% patients of MIBC treated with cystectomy alone will progress to metastatic disease. And chemotherapy is better tolerated before surgery rather than after surgery. And patients with micrometastatic disease will receive the therapy at an appropriate time when the burden of disease is potentially low. Next slide. Thirdly, potential, it can downstage a bulky and locally advanced disease by allowing for thereby there is a higher likelihood for having negative surgical margins. And as all of you know, positive surgical margin is a predictor of local recurrence following cystectomy. The basic disadvantages of neoadjuvant chemotherapy being there can be a delay in the definitive local therapy, and there is another doubt that there can be disease progression in non-responders. Next slide. Commonly, cisplatin-based neoadjuvant chemotherapy is employed, and when neoadjuvant chemotherapy is used, it has been found that there can be an improvement in overall survival to the tune of 5 to 6%, and pathologic complete response to the tune of 30 to 40%. And currently, according to the NCCN and EAU guidelines, recommended neoadjuvant chemotherapy is cisplatin-based neoadjuvant chemotherapy for clinical T2, T4A, N0, MGO disease. But I would like to highlight that neoadjuvant chemotherapy is underused even till now. Next slide. So there is another protocol known as the bladder preservation strategy. What does it mean by bladder preservation strategy? It includes maximal or radical TURBT combined with chemotherapy and extended beam radiotherapy and followed by cystoscopic re-evaluation. Next slide. Next slide. So in such cases of bladder preservation, one have to do appropriate surveillance of the patient with regular CT and cystoscopic re-evaluation. Now, bladder preservation curative intent paradigm for those who are having high operative risk due to comorbidities and frailty, but the disease burden should be limited. There should not be any CIS changes, and they should have a good normal bladder for adequate bladder function. And another thing is that the patient intend to retain the bladder. This is an important factor for bladder preservation. Next slide. There are two basic protocols. One is split course therapy and one is continuous course therapy. Split course therapy based on the premise of mid-treatment restaging. First, and this is advocated only in those surgically fit for immediate salvage cystectomy. In such cases, first is induction chemoradiation, then restaging of the disease with cross-sectional imaging and endoscopic evaluation. Next slide. So next slide. In those who are having a persistent invasive disease, one should go for radical cystectomy, And if there is no evidence of any invasive disease, then one can go for consolidative chemoradiotherapy. Next slide. Continuous course therapy. Here, full course of chemoradiotherapy is advocated. Thereafter, endoscopic restaging at 3 to 4 months later. Next slide. So what is the chemotherapy commonly employed? Nowadays, it is gemcitabine and cisplatin-based regime. Gemcitabine is employed because it has got a similar survival advantage, but it's at a better safety profile compared to MVAC. And patients who are unfit for cisplatin-based therapy, carboplatin is the agent. Next slide, please. Follow-up of these patients, imaging consists of CT imaging and cross-sectional imaging of the abdomen and pelvis with CT MRI at 6 to 12 months interval for 2 to 3 years and thereafter annually. This is as per the AUA. Next slide. Laboratory assessment should be done 3 to 6 months interval for 2 to 3 years. This includes complete blood count and serum metabolic evaluation. And those patients who are having a retained urethra, monitoring should be done for the urethral remnant with regard to recurrence. Next slide. In case of EAU, also EAU guidelines also suggest almost the same thing. CT scan 6 monthly for 3 years, then annually. Next slide.
Dr. Rajiv? Dr. Rajiv? Hello? Hello, Dr. Rajiv?
Dr. Dipu.
Yeah, I think he lost his.
He lost, and skip him and go forward.
Okay, okay. I think he may lost his connection. Professor Maula sir.
Conclude the session of Dr. Rajiv regarding his presentation.
Lenin,
I don't know what has happened.
Lenin, how are you?
Hello, Dr. Rajiv.
Dr. Rajiv.
Continue the slide. Two more left only.
Okay,
Rajiv
okay.
is speaking, but
Okay, Rajiv is trying to talk.
Yeah.
Okay.
yeah, continue,
Okay.
please.
So,
Okay. Now, nowadays, ASCO has, can you show the slides if the slides are available?
No, okay, continue, please. The slide is not seen.
So as ASCO have said that they are going a trial again with the nivolumab, gemcitabine, and cisplatin, and they have found that nivolumab is a PD, this immune checkpoint inhibitor. Next slide. They are having this trial with the nivolumab, gemcitabine, and cisplatin in muscle-invasive bladder cancer undergoing cystectomy, and they have found that this is in the phase 3 trial. There can be a pathological downgrade to the tune of 60% and pathological complete response rate into the tune of 50%. Next slide. Pembrolizumab is a PD-1 receptor blocking both immune suppressing ligands PD-L1 and PD-L2. And this is basically used in locally advanced or metastatic urothelial carcinoma. Indications are those patients who are ineligible for cisplatin containing chemotherapy, tumors expressing PD-L1. Next slide. Disease progression found during or following platinum-based chemotherapy or within 12 months of neoadjuvant or adjuvant treatment with platinum-based chemotherapy. It is advocated in the dose of 200 milligram IV once in 3 weeks or 400 milligram once in 6 weeks until there is disease progression or unacceptable toxicity. Otherwise, it can be continued for a period of 24 months. Next slide. So to conclude, I say this is bladder cancer is one of the costliest cancer in regard to treatment, especially muscle invasive bladder cancer. Establishment of diagnosis by cystoscopy biopsy is mandatory. Staging of the disease with contrast enhanced CT abdomen and pelvis should be done. Radical cystectomy with bilateral pelvic lymph node dissection with neoadjuvant chemotherapy is the gold standard treatment. Next slide. Bladder conservation strategy can also be tried in selected cases. And there are recent drugs coming up like nivolumab, pembrolizumab, which will add hope for a prolongation of the survival. But strict follow-up is mandatory in such conditions. Thank you for the patient hearing.
Presentation regarding the muscle invasive bladder cancer, but unfortunately,
মাওলা স্যার আনমিউট করেন আপনাকে।
go to the next session, especially the expert opinion from our panelist expert. Especially, I request our panelist expert to give some few comments regarding webinar overview on bladder cancer. Especially, I request Professor Nurul Lelin. Lelin sir, could you hear me?
Yes, how are you, sir?
Yes, fine, thank you. How are you?
Oh, fine by the grace of Almighty up till now and by the blessings of you.
Yes, yes, because we are now in a hard, terrible situation due to pandemic environment.
Yes,
This type of meeting can give some inspiration to share each other during this environment. But I request you, if you pass any expert comment regarding this meeting, please.
First of all, I must thanks to the BAUS Secretary General and others associated members who have arranged such a nice program and taken the burden to continue it. And second thing,
Congrats.
whatever in this
Excellent
COVID
presentation.
situation,
With some disturbance, it is an excellent presentation.
excellent presentation. No disturbance. This is somewhat a little bit of technological failure. No disturbance. And first thing I want to comment about that when a patient in this COVID situation, when a patient comes with a ultrasonography report that he has got however small, however large mass it is, we must go for a diagnosis by cystoscopic and TUR BT. Don't go for any cytological analysis of this patient because patient will go here and there. There will be no pathologist, there will be no diagnostic center will be there. You just help this patient. And this patient should not be waited for 11 months, not a day even. Because the day patient, now he is symptomless, but in the following day, but in the following night at 2 p.m., he will be symptomatic like torrential hemorrhage and clot retention, and he will go here and there, and he and his relative will be puzzled. So first thing, in this COVID situation, we must have to take the burden and risk of this patient on ourselves and on this patient also. When a patient with a ultrasonography report says that he or she has got a bladder mass, we must go immediately for cystoscopy and transurethral resection of the bladder tumor. Now, second thing, in this COVID situation, if you see that the patient has got a muscle invasive bladder tumor, you can buy time. During this time, you can go for the neoadjuvant chemotherapy and buy the time to heal the COVID situation and go for the radical surgery afterwards. The neoadjuvant chemotherapy is being advocated. And you can buy this time and wait for this time to have an extensive surgery because you know that surgeons are at stress during this stressful condition. The staff, OT staff, everything there is a very extensive surgery. But TURBT is, I think it is a very well regulated and it requires much less people and much less time. The second thing is this. And the third thing is what about the Mutahar's paper, Professor Mutahar's paper, about the en bloc dissection. I think en bloc dissection is a very fantastic method of resecting the bladder tumor of less than 3 centimeter. But if we add a newer technology like water insufflation technique around the mucosa and the muscle around the stipulated margin of 1 centimeter, then the mucosa will float over along with the tumor, and the resection is much easier than that of the non-insufflation technique. So, during the en bloc dissection, we should advocate the water insufflation technique around the margin, 1 centimeter margin around the tumor, and the resection of the tumor is inoculation of the tumor, I must say inoculation of the tumor is much easier than that of the normal diathermy technique, only diathermy technique. And another advantage is that if we add the water instabilization technique, then there is much less incidence of obturator jerk, initiating the obturator jerk. That is another hazardous environment on the part of the resector to resect the tumor as a mass and envelope resection. And I think wherever it is possible, envelope resection is much superior to piecemeal dissection because of the tumor implantation and recurrence and positive margin for the masses. And another thing is regarding the lymph node dissection. During the lymph node dissection, if it is particularly if the patient has received radiotherapy prior to the resection, we must have a PTFE graft at hand so that if there is any vascular injury that can be tackled off and that have the measure to save the life of the person, and we can complete the surgery as a whole. Thank you all.
Okay, thank you very much, Professor Lelin, for your, I think, nice commentary. I think especially request Professor Sabbir Ahmed Khan. Sabbir Ahmed sir. Professor Sabbir Ahmed Khan, can you?
Yeah,
Okay,
I'm hearing you.
Okay, thank you very much. I think
Thank you.
please within short.
Okay. Thank you, BAUS President and Secretary, and also the BAUS executives for arranging such a nice webinar continuously. And also by this way, they are reducing the tension over the shoulder of the from the shoulder of the urologist, because we are facing very hard time or unpleasant time globally, not only in Bangladesh but also in whole over the world during COVID. And the presenter, Professor Chaudhary, Dr. Motahar Hussain, and also Rajiv, they are very nicely cited and also presented early non-invasive bladder and muscle invasive and also advanced malignancy of the bladder cancer. So I think it will enrich our knowledge, not only us but also the younger urologists, those are watching. I think for this reason I must thanks to the presenter and also thanks to the BAUS executive, so that my suggestion is to this is it should be a continuous way, so that we can continuously connect it with the external world in this COVID situation. Also, the treatment modalities actually varies from stage, grade, and also the patient choice and the country where we are staying. Actually, the treatment modalities depends upon the facilities that we are enjoying in our country, or that we are enjoying the other urologists. So modalities maybe varies from countries to countries. So I must thanks to all of the presenter and BAUS. Thank you very much.
Okay, thank you very much, Professor Sabbir Ahmed Khan. Next, I request Brigadier General Professor MD Shahidul Islam. MD Shahidul Islam, Professor Shahidul Islam, can you hear me?
Yes, sir. Assalamu alaikum.
Okay.
Can you hear me?
Assalamu alaikum. Thank you very much, sir. I think I need some expert opinion from you.
Sir, thank you, sir. Actually, I am not expert, but as you honored me to say something, I feel myself a little elevated. Thank you, BAUS, for arranging such scientific session in the era of these very bad days. And at this moment, you know, the Combined Military Hospital, Dhaka, is facing tremendous pressure due to this COVID. Today's report, more than 900 in CMH Dhaka and a few other areas in Dhaka we are managing. And as a chief surgeon of CMH Dhaka, our surgeons, we are putting the surgeons to corona duties, nothing doing. Only I am assuring them that good days are coming. This is temporary. Pray for us. I must thank Professor Chaudhary, Dr. Mutahar Ahmed, and Dr. Rajiv for their brilliant and lot of informative presentations. First of all, I would like to say a few points. In addition to smoking and occupational carcinogens, other factors may play a role in causing the urothelial cancer, as a long latency period between exposure to carcinogens and development of cancer. There might be other additional culprits in the development, particularly in young people with no history of smoking, no occupational exposure. Patients who are presenting with hematuria symptoms must be thoroughly investigated with the appropriate imaging and cystoscopy. Various development in cystoscopic technique in the form of narrowband imaging and blue light cystoscopy. But here you see those, especially those markers, biomarkers, these are all elusive. So cystoscopy is basic. Here a lot of changes, and probably this narrowband imaging, once we apply it for initially with the blue light and the green light, the blue light, the upper part, and the green light, lower part, they can very well identify, and they can very well delineate many of the tumors, which is really difficult to identify white light. This is one point. And regarding the diagnosis, our Professor Chaudhary said this upper tract investigation for all cases. This is more or less same for the NCCN and the UAE. They say all for all cases, but for UAE recommendations probably not for all cases. They have some limitations. They trigonal areas or recurrent tumor this type. So AUA, they recommend upper tract investigation for all cases, but probably this European, they vary to some extent. And regarding a few other points, I would like to say this is the intravesical chemotherapy. And few days back, probably you have seen the lot of BCG vaccines are not very readily available. In that case, probably people started thinking other than BCG, any other like gemcitabine, etc., and mitomycin and gemcitabine, etc., because the BCG was not readily available in some areas a few days back. Regarding the tumor, I would like to say the resection is the utmost. Especially, you have to resect completely with the base initially to avoid the further restaging. And in that case, I would like to share one: if your residents and your new urologist, they resect, it should be supervised. We should see whether they are taking the full base of the tumor at a time. Otherwise, I have seen many of the tumors, they are coming with just few days back, they resected, and the patient does not know, they don't know, and they tell that resection was done. And they came with lot of recurrences. And when I went through the papers, I saw probably the seniors are not involved. This is my observation in my private practice. This is my one suggestion. And another point, when we give some discharge slip to the patients, we just write here, I think some mapping should be done so that you can give one paper to the patient and another sheet you keep in your record so that it is helpful for futures. And I would like to say the high rate of tumor recurrence and risk progression in high-grade tumors may be reduced with this adjuvant intravesical immunotherapy and also combination therapy. And I would like to say that the perioperative chemotherapy has been used to downstage tumor, treat any occult micrometastasis in muscle invasive cancers before radical cystectomy. So this is this adjuvant therapy we have to consider, because once it is muscle invasive, you have seen probably many authors, they want to say that this is micrometastasis, systemic disease. So in that case, probably if patients performance status and other permits, then perioperative chemotherapy, neoadjuvant chemotherapy can be considered. And especially during this period, if we can consider the neoadjuvant chemotherapy, but we may get some time so that we can help the patient. Otherwise, the disease, if you wait for 3 months in case of muscle invasive, I think that is the time this condition will be beyond our control. So neoadjuvant therapy can be considered at this present if it is possible. Radical cystectomy, yes, currently the mainstay of treatment for muscle invasive bladder tumor. The procedure is life-changing operation, and the bladder preservation strategy using this chemotherapy, ERBT, this is also an option because, many of the cases, this is a very big operation. Patient quality of life may change. So,
sir, we are 15 minutes behind, sir.
And other few, I would like to say that this in-block dissection actually, Europeans, they are very much eager to do this in block, but practically I do not know with your hand. In my setup, I have tried the larger one and I face a lot of difficulty to dissect because of the huge bush and to bring out this specimen. So in that case, I do not know. I would like to hear from Professor Chaudhary regarding this in-block dissection, how much it is feasible.
We are running
for
short
small
time, sir.
This is not required. Okay, sir. I would like to say that in-block dissection, at least to me, it is not comfortable. I have seen this is difficult. It's for large tumor. Small tumor, for that in-block dissection is not at all required. You can just chop it up with your conventional dissection. Thank you, sir. Thank you for arranging such a beautiful session, and please keep it in future also. Thank you.
Okay, thank you very much, Professor Shahidul Islam. Now, yes, Professor M.D. Amanur Rasul. Can you hear me? Professor Amanur Rasul? Professor Amanur Rasul, can you hear me?
Is he with us or not?
Okay. I think maybe he's not with us right now. Okay. Switch over to Professor M.D. Shahadat Hussain. Professor Shahadat Hussain, can you hear me? Professor Shahadat Hussain? Are you with us?
Yes, I can hear.
Huh?
Can you hear me?
Yes,
yes. Yes, Professor Shahadat. Okay.
Thank you.
Shahadat bhai, bhalo achen?
Thank you, Shahadat.
Good evening, everybody. Thanks, Maurus, for arranging such a nice webinar in this COVID situation, and special thanks to the speakers, and especially from USA who are contributing for us in such a late night for them. And after the lecture, we have actually little to speak about the subject. They have covered everything. I would like to I have some comment about the diagnosis of the diagnostic evaluation of the non-muscle invasive bladder cancer. The controversy has arisen about the upper tract imaging, but the guideline says it is a clinical principle, not recommendation to image the upper tract during the initial evaluation of the bladder tumor. If we think that this is a low risk tumor, we can omit in the in initial evaluation the upper tract upper tract imaging. And if we find a macroscopic lesion or tumor in ultrasonography, we can omit urinary cytology as well. So these these depends on individual situation, individual case. And we have some difficulties regarding the new adjuvant chemotherapy and all. If we refer the patients for new adjuvant therapy, most of the time the oncologist in our country they denies giving new adjuvant chemotherapy. So I think BAUS should arrange some interactive session with oncologist and pathologist regarding this. So
Thank you.
There is shortage of time. There are a lot of things to be discussed about these important topics, but now I thank everybody.
Okay. Thank you very much, Professor Shadat Hussain. I think these interesting topics and need some discussion. We could think and later on next session in near in future. Okay, thank you very much. Finally, I asked Professor ATM Maladat Chaudhary. Can you hear me? Professor Maladat Chaudhary.
Is he with us or not?
Sir, can you hear me?
Yes, we can hear you.
Yeah, thank you, sir. Thank you, sir. Thank you, sir. First of all, I would like to thank the BAUS officials for their thank you, Lavin bhai, for their relentless and incessant nice efforts. And I am grateful and quite thankful to all the speakers because they elaborated all aspects of bladder tumors quite nicely. So I don't have anything to add there, but I would like to comment on some aspects of our practice. That is the limitation of our practice. One is our camera system, the clarity of vision. In all areas where we work, these good facilities are not available. The camera system that we use is not up to the mark. The high definition camera and the usual camera, the resection quality varies tremendously. With the ordinary camera, we are not confident, and most of the times we are not confident that we completed the resection completely. So we should try to improve this facility wherever we work. This is one. And second thing, the histopathology. We don't have dedicated genitourinary histopathologists. I don't know when and how we will overcome this limitation, but we should concentrate and we should encourage the people to come here. And the last thing is follow-up. And many things, our results remain inconclusive due to lack of follow-up. Our patients remain very much reluctant. So my request to all of the urologists of our country to keep database of the patient and take the responsibility to pull them in follow-up. You call them that this is the time of follow-up. You come here and check. Otherwise, our study won't be enriched, won't be authentic, and ultimately we won't be rendered to render the standard service to our people. These are all. I don't want to talk much because we are running short of time. I think you noticed. Thank you very much. I pray for all of us for our safe health. Allah keep us healthy in this pandemic situation, wherever we live, wherever we stay. Thank you very much once again. Allah Hafiz.
Thank you very much, Professor ATM Maladat Chaudhary. I think we are at the end of our session, not session, the presentation. But again, I pay my thanks to Professor MS Chaudhary, Professor Rajiv Titi, Dr. Muhtar Hussain for their beautiful presentation, and lot of discussion was going on in this seminar, and a lot of benefit participants are getting from you. And lastly, say that Allah keep all of us well and stay safe, and pray to Allah for all of your well-being. Thank you very much. Now, I say to our boss that they organize such a beautiful semi-live webinar Zoom meeting and gives us a beautiful communication between us. Especially thanks to Deputy Professor Habibur Dulal, President of BAUS, and Secretary General Dr. Sohid Mohammad Saiful Hussain for their effortless support. And finally, I give thanks to our sponsor, especially the UniHealth, UniMed, for their continuous support. Thank you very much. Now, I would like to say that Dr. Dipu, you should conclude the session finally.
Professor Ghulam Maula Chaudhuri sir, thank you very, very much for excellent moderation of this very nice topics, and the commonest topics and commonest disease in our country and throughout the world also, and the most common disease in the uro-oncology, bladder cancer. I hope our all presenter, I hope all our participant and viewer immensely benefited by this. I must give thanks to our today's speaker, Professor Chaudhuri and Professor Ahmed and Professor Rajiv Tipi. Rajiv Tipi left this webinar because he has another webinar in the Urology Society of India. And I must give thanks to a panel of experts, those who give their excellent comments, and particularly Professor Nurul Huda Lelin, who gives a very brief nutshell comment regarding the disease, and all other panel of experts also give a very nice commentaries. Professor Chaudhuri sir, can you hear me? Professor Chaudhuri sir, Professor MS Chaudhuri sir, are you with us? Professor Chaudhuri sir, are you with us? Okay, Professor, I think Professor Chaudhuri sir will left. Professor Chaudhuri sir, are you with us?
Yes, I can hear you.
Okay, sir. Thank you, sir. So most of the question answer is given by the Dr. Ahmed in chat box. So I think there is no other question left to you. So finally, I request you to give some comments and to give the future guideline for continuing the scientific program and session and so on. Sir, please, you are the mentor of our mentors. So you are the grandfather mentor of ours. Sir, please.
So once again, thank you. First of all, I think it was a wonderfully done event. I personally learned a lot. I think a lot of the comments, I think really kind of tells you that you got to cut the code with the cloth you have. So you always have to adjust with the local situation. And I think some of the comments are very, very appropriate really in this one. But I think we always got to have some goals that how we improve things. So let's say in bladder cancer, how do we improve? And I think Dr. Ahmed gave some guidance on this one, such as how do we collect the pathology? How do we improve the uropathology situation in Bangladesh? Believe me, it's not a challenge only in Bangladesh, challenge in a lot of part of the world. But I think we can improve on those things. I think Dr. Chowdhury mentioned also about the video system. All of these can be improved and things. But I think we should stick to some of the guidelines that the treatment of bladder cancer got to be standardized, right? If it's not standardized, then it becomes an issue really in this one. But I think I have seen things have improved significantly even in the past 10 years. So I think there's a lot of room, we have room for improvement everywhere, including in Bangladesh. But I think BAUS is doing a great job of doing all these webinars during this difficult time. I think we can all learn something. I certainly will always be available if needed. For any future webinar, and I'm sure Dr. Ahmed is always going to be available also for you. But this was a very well done thing. So thank you. Goes to the BAUS Executive Committee for a job very well done.
Thank you, sir, for my heartfelt gratitude to you Now, Dr. Ahmed, can you say something to Baus and also all the participants, please? Dr.
Okay.
Ahmed.
Okay.
Yeah.
Can you hear me? Yeah. Assalamu alaikum again.
Ahmed, how are you?
No, it was, thank you everyone for inviting us and hosting such a beautiful program. And I think everything worked out well, as Dr. Chaudhary mentioned. And I mean, it's a very difficult, bladder cancer, as I said, is most expensive, right? Dr. Chaudhary is the most expensive DRG for US. Am I correct? I mean, you are mute.
Diagnosis is very expensive, correct.
Yeah. And it gets very complex, but you have to keep it simple. Think simple. Whenever you see a bladder mass, you want to do as simplest stuff. Make sure you do the things right for the patient. And I agree with Dr. Lennon that you see a bladder mass, you should do TURBT. You shouldn't put it off. You shouldn't wait weeks and weeks. But you also want to get a proper diagnosis. So when you do the TURBT, please make sure that you have enough specimen. Please make sure you have muscle, because it will be very hard for this patient to come back and get anesthesia. It adds cost. So at least if you could get a muscle on the first time, it will be very beneficial, especially in a high grade situation. And a lot of time, what I see in the district level, in Dhaka, I think situation is pretty good. But out of Dhaka or outside, please try to bring the specimen and go over with somebody you trust. Because going over and knowing the pathology, it's not just about scraping it. 6 months later, this patient will have the disease come back. So if you get the proper diagnosis, then you can do the proper treatment. And you could counsel the patient properly. If it is a low grade, you know he's not going to die from the bladder cancer. But if it is a high grade, this guy needs a good follow-up. And he has to be at least made to understand that. That's basically it. It's a complex subject, but try to keep it simple and make it easy for the patient. So then they can understand as well. Thank you very much.
Thank you very much. My heartfelt thanks to you also. Thank you very much, because we immensely benefited those who are the practicing urologists, and definitely it is a wonderful review of the all the urologists, and very much benefited for our loving juniors and loving residents. So now I invite Professor Ishtiaq Ahmed Shamim, who is our scientific co-chair. Sir, please give a vote of thanks to all the speakers, viewers, presenters, panel of experts, and me too also.
Can you hear me?
Yes.
So, respected Professor Habibur Rahman Dulal, the president of BAUS, it's been a real pleasure to be here and speak on behalf of the scientific committee and the BAUS to all the viewers. It is a great opportunity, because we have seen during this pandemic tragedy, every day we are coming up with very depressive news in the morning, afternoon, all the time. But the last 2.5 hours was very absorbing. We have learned a lot from all the three speakers, all the good discussion from the panelists, and a wonderful moderation from Dr. Professor Ghulam Maula Chaudhary. But first of all, I would like to thank our dynamic Secretary General, Dr. Tawhid Mahmood Saiful Hussain. He's an inspiration for the next generation, I'm sure. He's working hard. He discusses with all of us, but he does almost all the work by himself to arrange all such kind of webinars. So first of all, my thanks to all the three speakers, Professor Chaudhary and Dr. Mutar from USA. I'm sure they didn't have a good night's sleep last night, because it's very early in the morning when they wake up. But still, they are with us for the last many years, and I'm sure they're going to continue for more decades to come. And we are going to benefit from them day by day. And also to Dr. Rajiv TP, who is a very busy webinar nowadays, very faculty, because he has left us for another webinar, but our thanks to them. And my heartfelt thanks to all the panelists and all the participants. They are the oxygen of this occasion. So when I see so many participants participating, taking part in discussion, we really feel encouraged. So I am thankful to all of them, to our Secretary General, especially Dr. Tawhid Mahmood Saiful Hussain, the scientific chairperson, and also the scientific secretary, who are all behind all this arrangement. But finally, I must say, it's nothing, not very important, our scientific partner, UniMed and UniHealth. They have been with us for the last 10 years or more like that, and they've been doing a wonderful job. Without them, we could not have arranged all these webinars and everything all these years. So thanks to them, and thanks to everyone for their wonderful participation. And we look forward to more of such kind of webinars in future also. Dr. Mutar and Chaudhary sir, please accept my sincerest thanks to you all. Thank you, Dipu.
Thank you, Professor Ahmed, for your excellent vote of thanks. And really, a scientific committee is the core of a society. So we hear from you the excellent talk from the scientific committee. Now I invite our honorable president, who is a dynamic president, who always guide me by his inspirational talk. Dr. Dipu, do and do, I am with you. So now I invite our president, Professor Habibur Rahman, to give him in final remarks and concluding remarks, and also the presidential talk. Professor Habibur Rahman, sir.
Thank you, Dr. Tohid Mohammad Saiful Hussain Dipu. Everybody know Dipu is very dynamic and is running these bows very nicely, sincerely, with devotion. First of all, really I'm very grateful to our foreign learned speaker, Professor Amit Chaudhary sir, Professor Rajiv Tipi, Dr. Mukhtar Hussain, for their nice association with us. I convey to my gratitude to all the senior teachers, all members of my BAUS committee, my scientific committee, our panel of experts, and all my beloved residents who are watching this program. We are committed to continue such kind of webinar session during this pandemic situation that is halting our day-to-day activities. Actually, bladder cancer is a vast subject. It is a very elaborative. There is so many situation, so many controversial issues which cannot be finished by one webinar. We have, we think we will continue this webinar on carcinoma bladder, especially we'll arrange a webinar, interactive webinar on bladder cancer, including our pathologist friend and our radiological friend and so on. Actually, in this COVID situation, it is very difficult job for us, especially the urologist, because we have to do some surgeries. Without surgery, we cannot manage our patients. We have a plan. We'll arrange a webinar regarding the current situation of pandemic of our country and how to really start our emergency and elective activities in future, because we can't stop our duties for a long period, because this pandemic situation and the COVID situation will continue us, and we have to run with this situation. So everybody have to start our please think yourself, and everybody should contribute to the, that webinar. Lastly, I pray to Allah and pray to Allah for the early recovery of our members and the members of our community and the whole countries, those who are suffering from this COVID situation. And I pray to Allah will overcome this situation with the mercy of Allah, and everybody stay safe and save our nation by the grace of Almighty Allah. Lastly, I am thankful to our regular scientific partner, UniMed UniHealth, for their continuous support. Thank you, everybody. Allah Hafiz.